In this section, we're going to be talking about the anatomy of the urinary tract, the different organs involved, and their function. So just an overview, urine, it's a sterile solution. It's produced in the kidney. It's a result of the filtration, secretion, and reabsorption of electrolytes and water that occur in the nephron. The renal pelvis of each kidney, just to review, the renal pelvis is in each kidney, and then you have the nephrons, which all converge and release their filtrate into the renal pelvis. And then the renal pelvis is where the ureter begins. So the ureter comes off the renal pelvis and transports the urine to the bladder. And then once the urine reaches the bladder, that it's stored, and then when the body is ready to expel it, it is expelled via the urethra. An important thing, kind of a histology note, is that there's what's called transitional epithelium. It's a unique type of epithelium that lines the luminal surfaces of the ureters, the bladder, and the urethra. And what it is it's kind of a stratified, or almost pseudo-stratified epithelium. And it has this top layer here, which can expand. And so what happens is, when it kind of has this dome, this top layer will have this kind of like dome shape to it when it's empty. And then what can happen is it can flatten. So if, like, say for the bladder, for example, the epithelium on the top can flatten like this to accommodate expansion of the bladder to accommodate urine. So the ureters, they're paired long muscular tubes. They're about 25 centimeters long, and their function is to transport urine from the kidney to the bladder. And you can see them here in the diagram here. So here's the one ureter here, and then here's the left ureter here. And as you can see, they traveled all the way down through the abdomen and into the pelvis, and they do that by peristaltic waves of smooth muscle contractions. So they have a very thick layer of smooth muscle, which act to contract and move the urine along. When they're descending in the abdomen from the kidney, they're retroperitoneal. Very important concept, very important surgical concept. Whenever you're doing surgery in the pelvis, the surgeon always wants to identify the ureter and avoid injuring it, and we'll talk about why that's important in a second here. So when it travels down, so the bladder, it travels down retroperitoneal, and then it enters the pelvis by crossing over the pelvic brim. So the pelvic brim is about right here where the iliacs are, and it's where the bifurcation of the common iliac goes into the internal iliac and then the external iliac here. And so this is where it enters the pelvis. Once within the true pelvis, so once it's crossed over the brim, it runs medial to the umbilical artery and obturator vessels, and then anterolateral to the interior iliac. So here's the iliac here, and then it's kind of traveling in here like this. After traveling along kind of the lateral wall, so it's kind of hanging out here, if you look at the diagram, it kind of turns anteromedially at the level of the ischial spines, so those bony landmarks in the pelvis, and then it joins the bladder, kind of creating it at an oblique angle, so like this. So just to kind of blow this up here, so you got the bladder here, and then you have the ureters coming in from both sides like this, and then that's to join the bladder and bring the urine in. So they're coming in it this way. And what this does is it kind of creates a natural, like, tissue kind of valve on both sides that it's really regulated by the intramural pressure of the bladder. And so when the pressure in the bladder, so as the bladder if the volume's kind of low in the bladder, pressure's not very high, okay? And so these valves don't really provide much resistance, and so urine can kind of just easily flow in. Now, as the bladder gets more full and the pressure goes up, then there's kind of some resistance here and resistance here, and the pressure buildup in the bladder kind of prevents any more flow of urine into the bladder itself. It also, and by closing these valves, you prevent any kind of retrograde flow of urine back into the ureter. The ureter has some very important spatial relationships in the female. They're especially important to a gynecological surgeon. So if we look at this diagram here, it's a posterior view. So it's the posterior view of the uterus and the ovary. So what happens is the ureter will come in just over the pelvic brim, and it'll enter the pelvis, and it'll travel posterior to the ovary. So the ovary here lies anterior to the ureter coming in. And this ovarian artery is very important because it's traveling within the suspensory ligament of the ovary. So the suspensory ligament of the ovary carries the ovarian artery. And this is important surgically because during an oophorectomy, which is a surgery to remove the ovary, typically done for like a cyst or ovarian cancer, what happens is the surgeon needs to be very careful to locate and isolate the ureter, because if you're not careful while ligating the ovarian artery, you can damage the ureter and cause accidental ligation of the ureter. And we'll talk about why that's really devastating in subsequent slides. So what happens is after it travels posterior to the ovary, it travels down this way, and we'll kind of join our ureter with the ureter of the diagram here. And so this shows the ureter doing that water under the bridge concept. So the ureter then travels, and again, remember this is a posterior view, so the ureter travels underneath the uterine artery. So it's shown here, this is kind of the under view of the bridge of the uterine artery here. And this is within like the broad ligament. So within the broad ligament of the uterus, you have the ureter traveling in and going underneath this uterine artery. And this is just lateral to the uterus. So this is really important during a hysterectomy. So what they'll do is they'll ligate the uterine artery to prevent any excessive bleeding while to remove the uterus. And so again, the ureter needs to be carefully identified and isolated so that it isn't ligated. So that's another thing that can happen. If they're not careful, they can accidentally ligate the ureter and again lead to significant problems. These are two concepts that are very highly tested on board exams, so these are definitely two relationships you want to be aware of. So the male, it's a little more straightforward. So here's the ureter here in this diagram. So it comes down here. As you can see, it kind of latches onto the posterior surface of the bladder here, and it travels posterior and just underneath the vas. So here's your vas right here. So there's your vas. So the vas deferens travels here, and it lies just underneath the vas. So in the female, the ureter travels underneath the uterine artery. In the male, it travels underneath the vas deferens. So as we kind of highlight here in the text, underneath the vas deferens. And then it lies anterior to the seminal vesicle. So here's your seminal vesicle here. The blood supply to the abdominal region of the ureter is via the renal artery. So you have branches off the renal and the testicular or ovarian artery, depending on which gender it is. Branches from those arteries will supply the abdominal region. The blood supply in the pelvic region is via the superior and inferior vesical arteries. So you have smaller branches off these arteries in the pelvis that supply the ureter. The venous drainage is just veins corresponding to the artery in each region. The innervation is provided by nerve fibers from a number of plexes, the renal plexus, the testicular and ovarian plexus. These are kind of those smaller organ-specific plexuses that are distal to the inferior hypogastric plexus within the pelvis. So nerve fibers will travel through the inferior hypogastric plexus, and then they'll make their way to these plexuses and form synapses in there. And then, of course, the hypogastric plexus. Sensory fibers will enter the spinal cord at the T11L2 level, thus referring ureter pain to those dermatomes. So if you have, like, for example, a renal stone, or stone in the ureter, this is where the pain will be felt in these dermatomes. 3 points of narrowing in the ureter. Now these are important because they're areas where stones can develop. Stone can develop anywhere along the ureter, in the abdomen and in the pelvis, but these are 3 points where you especially could have development of a stone because it's where the lumen will narrow. So again, here's your renal pelvis. Here, and then it kind of tapers down and forms the ureter here. So this narrowing here is number one, the uretero-pelvic junction. And then down here, where you have the ureter kind of traveling here across the common iliac at the bifurcation, just over the pelvic brim. So kind of that, it's kind of in a close proximity to a lot of structures that can compress it and cause and further the narrowing. And then also at the site of entering the bladder, so where it comes down here and enters the bladder. And again, just to kind of show that again, so here's the bladder here. And so the ureter kind of comes in at an oblique angle to join the bladder, and then that kind of creates these valves, these tissue valves we were talking about. So again, this is where there's a narrowing as well where you can have formation of stones or other debris to block passage of urine. So the stones form from minerals within the urine and obstruct urinary flow, and they cause severe pain. The classic pain, especially in a ureter stone, is kind of the loin to groin pain. So your loin is kind of your back, your flank region here. So you'll have the pain, and it kind of, they'll talk about it radiates from like the flank region of the back, and then it radiates down here to the groin area. So that's your loin to groin pain. That's the classic pain presentation. You also can have hematuria. So painful hematuria. You definitely want to be thinking about stones. Stones are very, very common. So anytime a patient will complain of pain and hematuria, stone is definitely high on the differential. Again, clamping or ligation of the ureter, so especially when we're talking about like those gynecological surgeries on the ovary or on the uterus. The gynecological surgeons are always extremely careful to make sure to isolate and protect the ureter. And the reason for that is if you block this ureter, if you ligate it here, say, the pressure is going to keep building up here, and it'll go all the way back up into the kidney. And then what happens is the kidney develops at an abnormally high amount of pressure, and then it swells. And this is what's called hydronephrosis. And this can be detrimental to the kidney and lead to acute renal failure. Which is a very serious condition and needs to be treated emergently. So a common board type question is, a woman had an oophorectomy, and then later on she presents with flank pain, and then they do an ultrasound and they find hydronephrosis in the kidney, and the question will ask you in some way or another what exactly happened. And usually the answer is something like, oh, the ureter was ligated while or was accidentally ligated while ligating the ovarian artery and the suspensory ligament here, or if it was a hysterectomy, it would have been, while ligating the uterine artery, they accidentally ligated the ureter down there. So to move on now to the bladder, kind of the more distal organ in the urinary tract. The bladder in both genders, so we have diagrams here showing both the bladder within both genders. It's situated below the peritoneum, so here's the peritoneum kind of draping down like this, and then again here in the male, the peritoneum draping down like this, just over the top of the bladder. It's a very distensible and muscular organ, which makes sense for its function. It's got to accommodate the urine, so you want it to be able to stretch, but then at a certain point when the person's about to urinate, you want it to be able to be very forcefully contract and push all the urine out. So just some anatomical components of the bladder. One thing I'll point out real quick is, so you have your pubic symphysis here and here. In both genders, doesn't matter, the bladder is just posterior to the pubic symphysis. So that's kind of like one of your landmarks you can use when looking for the bladder. So what you have is the apex of the first section is the apex of the bladder, which is kind of the superior anterior portion. So it's kind of this part right here, just behind this kind of, and then again here in the male, and it's just posterior to this pubic symphysis, and it's connected to the umbilicus via the median umbilical ligament, those ligaments we talked about in the abdomen. The body of the bladder is kind of the main part of the bladder, so it's kind of this large region here, and that's the main part that stores the urine. It's located between the apex and the fundus, so the apex down here, and then body here. Okay, the fundus is the posterior inferior region. It's kind of triangular shape. So the fundus is kind of this region here, this kind of pointed triangle shaped region at the top, which kind of is where the peritoneum kind of drapes over the fundus of the bladder. And this is kind of the most region here. So the neck of the bladder, the last part, that's what's formed by joining of the fundus and the two inferior lateral surfaces, and serves as a connection point of the bladder to the urethra. So this is the neck of the bladder right here, neck of the bladder right here. So so if we draw a bladder here, if we do like a sagittal section of the bladder, so sagittal. Okay, so we have our fundus up here. Okay, we have our body here, we have our apex here, and this is anterior and posterior, So you have the bladder kind of converges here on the neck of the bladder. So this would be your neck, and that's where your urethra will form here. So here's your urethra kind of coming off. So within the bladder, if we kind of open it up here, again, you can kind of see these kind of rugged surface here. That's formed by that transitional epithelium we talked about. Again, it's kind of a squamous, stacked epithelium, and then the top part is kind of forms that dome shape we talk about if it's not filled, so kind of dome like this. And then if you were to stretch the bladder, it kind of, this top layer here gets stretched out here, so it's more flat like this. And then so that top layer is really kind of gives it the distensibility, so it's flat like that. Okay. So what you have here is the trigone area, which is kind of here, trigone, kind of shaped like a triangle. And in this part is significant because it's nice and smooth. You can tell here that the luminal surface is very smooth. It's kind of helped facilitate flow of urine, because this is, if you look here, this is where the kind of the two ends here of the trigone is where the ureters will come in. So if you look at the ureter here and here, this is where these valves and these openings occur. So it's kind of facilitates a nice flow for the urine to flow right into the bladder. And then at the point of the trigone, you have the internal urethral orifice, and this is where the bladder joins the urethra. And so again, it kind of helps facilitate smooth flow of the urine out of the bladder and into the urethra. Now the walls of the bladder here, so these are the walls, kind of inhibiting. They have a specialized muscle called the detrusor muscle, so kind of located here in the walls, and it's smooth muscle, and it's what's responsible for contracting the entire bladder while during urination. So the sympathetic nerve, or the autonomic nervous system, will activate the detrusor muscle to cause it to contract during urination. So the expulsion of the urine from the bladder is regulated by two sphincters. You have the internal urethral sphincter, which is this right here. So that's the IUS, or internal urethral sphincter. And then you have just distal to that the external urethral sphincter. So the internal urethral sphincter, it's a circular ring of smooth muscle, very important. It's located just distal to the neck of the bladder. So here's our neck. And it's under autonomic control, very important. So external urethral sphincter, again, it's a circular ring, but it's skeletal muscle, very, very, very important. So this is skeletal, and then this is smooth. Okay, and it's located in the urethra, just distal to the internal sphincter, and it's under voluntary control. So this is when you have that urge to go to the bathroom, and you're sitting in class, you're sitting in a situation where you can't get up and go to the bathroom. So when you decide, oh, I'm going to hold going to the bathroom, this external urethral sphincter is what helps you do that, and it's under somatic, so kind of conscious control, somatic innervation to the skeletal muscle within this sphincter. So again, internal urethral sphincter, smooth muscle, ANS control, external urethral sphincter, skeletal muscle, somatic innervation. So the vascular supply to the bladder, so we have this diagram here. It's all coming from the interior iliac artery. So you have here the superior vesical artery, which travels right here. That's one of the main arteries. In the males, it's supplemented by the inferior vesical artery, which comes off here and then comes and supplies the bladder. In the females, it's supplemented. The superior vesicle will be supplemented by the vaginal artery. So branches off the vaginal artery will come and supply the bladder. The venous drainage is via the vesical venous plexus, which kind of drains into the internal iliac vein. So some clinical applications for the bladder. So main thing here is bladder carcinoma. That's a very serious disease. And it can originate from different types of epithelium. The most common is from the transitional epithelium, that transitional epithelium we talked about. So all the epithelium that kind of forms the luminal surface of the bladder. The classic presentation is painless. So remember we talked about stones were painful hematuria. Well, bladder cancer is notorious for presenting as painless hematuria. And the risk factors are cigarette smoking, or exposure to organic carcinogens in the workplace. So a classic example of this is like hairdressers, people that work with kind of hair products or hair dyes. Those can contain some of the chemicals that may put someone at risk for that. So a classic board question is often, someone in their kind of late 50s, 60s, been smoking for a long time, 30, 40 years, and then they come in with painless hematuria, and they're asking you kind of what the diagnosis is or what kind of process is involved. And so you want to be thinking about transitional epithelial cells kind of forming a cancerous process within the bladder. And another type that you can see on board exams is squamous cell carcinoma in the bladder. And this often shows up because you can have an infectious component to it. It's the schistosoma parasitic infection. So these parasites come in and they kind of embed themselves in the wall of the bladder, and that creates a significant inflammatory reaction. And so what happens is you kind of have a transition from the transitional epithelium, and it forms almost you could call it a metaplasia. You have a metaplasia that forms from transitional epithelium into squamous epithelium, and then that's what develops into a tumor. And again, these patients also will present with painless hematuria. Often on board exams, this can affect anyone, but often on board exams they'll talk about a patient from Egypt. I think this infection has a much higher incidence in the Egyptian and kind of the North African area. So if you see a board question about a 50-year-old immigrant from the Egypt or kind of northern African area, and they come in with painless hematuria, definitely be thinking about this, because they could give you as a presentation, and then they might ask, well, what's responsible for this process? And then one of the answer choices could be schistosoma infection. Tenesmus is a constant feeling of fullness and urge to empty the bladder or the bowel, and it's accompanied kind of by straining and pain due to the spasm of the urogenital diaphragm. So what happens is you have within the perineum, you kind of have that urogenital diaphragm that's spazzing, and it's kind of 1 minute it's obstructing urethra, another minute it's not. So these patients kind of it throws off the bladder and kind of that feeling of when it's full, and then also when they kind of have that urge to empty it. Interstitial cystitis, very common. You'll see this all the time in the hospitals and the clinic. It's an inflammation of the bladder mucosa. So it's kind of an inflammation process within the wall here. And it often is caused by infection, not always caused by infection. Another thing that can cause it is cyclophosphamide. It's kind of an anti-neoplastic drug, but this will cause hemorrhagic cystitis. So it'll cause an inflammation in the bladder wall, but that'll lead to hemorrhagic. Infection is not hemorrhagic. So infection, you just have these classic examples: the painful urination, increased urinary frequency. If you get a urine analysis, you could see white blood cells increase. You could see even bacteria. If you do a culture, you could see nitrates if it's a gram-negative infection. Okay, so for the urethra, the most distal part of the urinary tract, we're going to go through it for the male first and then the female. So in the male, it's responsible for transporting both the urine and the ejaculate. So you have many of the male reproductive glands that kind of converge on the urethra and release their secretions into the urethra to be expelled during ejaculation. Another important point is the urethra is much longer in males, and it has 4 different parts, which we'll go through. So for the 4 parts, the first part is the pre-prostatic part. So this diagram isn't the best at showing it, but it's kind of here in the neck of the bladder, and it begins at the internal urethral orifice and then ends here at the prostate. So that's your first part here. Second part here is your prostatic portion, traveling within the prostate, and it ends here. Important part about this region is you have the ejaculatory ducts that contain spermatozoa from the testes traveling in the vas here, and then also seminal fluid from the seminal vesicles. So you have your ejaculatory duct here, so ED, and then traveling into the urethra here, so this is your urethra. And then, so you have urine traveling this way, and then the ejaculatory duct, it receives contents from the vas, and then also the seminal vesicle here. So the seminal vesicle ducts empty in here, and they kind of form this ejaculatory duct, which carries both contents from the seminal vesicle and the spermatozoa from the vas, and then expels them both into the urethra to be expelled out. The membranous portion is a shorter part that passes through the pelvic floor. So this is the third part here, traveling through the urogenital diaphragm. And it's surrounded by the external urethral sphincter, and it's within the deep perineal pouch. Now, the last part is the spongy part, so part 4. It passes through the bulb and the corpus spongiosum of the penis, and it ends at the external urethral orifice, which is right here. Some clinical correlations. So if you're in the male, you have this angle here, which is the pre-pubic angle. So it's kind of formed here. And what happens is if you were to just put a urinary catheter in here, it would kink, and you wouldn't necessarily be able to get it easily within all the way up into the bladder, because that's the goal of the urinary catheter. Is you don't want it to just stop here. You want to get it all the way into the bladder so that you can continuously suction urine out of the bladder. So when you insert a urinary catheter in, is you have to hold the penis erect like this, and then you can insert the catheter in and you totally remove this angle, and it'll go in nice and smoothly and up into the bladder. 3 constriction points in the male, within the male urethra. The first one's at the internal urethral sphincter. The second one is at the external urethral sphincter, so down here, and then at the external urethral orifice. And that makes sense because you have 2 sphincters that can already kind of create some contraction on the lumen of the urethra, and so it would make sense that those would be constriction or narrowing points, and then the opening here, the final opening here at the external urethral orifice. Some clinical applications. Hypospadias. This is a congenital abnormality, and it's due to the failure of the urethral folds during development to close, and it results in an opening of the urethra on the inferior surface. So it would be more like the urethra would kind of open out this way, and these patients have a tendency to urinate more downward towards the floor. And then versus epispadis, which is an abnormal positioning of the genital tubercle during development, and it results in an opening of the orifice up this way on the more superior surface of the penis. So this is epispadis and then hypospadis. 2 congenital abnormalities that you might see on an exam, so just be aware of them. If you have an embryology textbook, you can read a little bit more about the abnormality that happens during development itself. So the female urethra, much shorter. It begins again at the neck of the bladder here, travels through the perineal membrane and the pelvic floor, and then you have the external urethral orifice. It opens between the labia minora and then the opening, and it's just anterior to the opening of the vagina, and then just posterior to the clitoris. And so due to it being much shorter in the female and having kind of a closer proximity, so here's the opening of the urethra, and then here's the opening of the anus here. So due to that close proximity, so you have a lot of floral bacteria here, and so what happens is it's very common, much more common in females to have urinary tract infections because the urethra is much shorter, so the bacteria doesn't have to travel as far to get up to the bladder, and then also since you have this kind of close proximity to the anus, where you have a kind of a buildup of bacteria in this region. And that closes out our discussion of the urinary tract.